So today we will discuss about the papillary renal cell carcinoma. It is the second most type of the renal cell carcinoma. It is one of the malignant neoplasm which commonly derive from the renal tubular epithelium. Predominantly, it has the papillary type of the architecture, which is the reason that it has the name as the papillary renal cell carcinoma. But at the same time, it can have a tubulo-papillary architecture, or it can have a microcystic type of architecture. It can have a solid, or it can have a microcystic architecture as well. Commonly, it has been seen that it commonly originates in the late age. The median or the mean age is 59 to 63 years of the age, and it has been commonly seen more in the male compared to the female. These tumors are commonly well circumscribed, and they are encapsulated as well, but sometimes they can have a pseudo capsule as well. These tumors commonly arises from the cortical region, and often bilateral and the multifocal compared to the other tumors. They are further subdivided into type 1 and the type 2, and these type 1 and the type 2, they commonly have a different molecular in origin, and they commonly have a different survival and their prognosis as well. And there are some tumors which can also have a papillary type of the architecture, so we have to pay extra attention on those type of the tumors. While grossly these tumors are oftenly circumscribed with the they commonly can have a encapsulation, or commonly have a pseudo capsule type of the structures. These tumors commonly undergoes necrosis and the hemorrhage. So that is the one reason these tumors are very fragile, and they can pour out of the kidney. And because they undergoes the necrosis and the hemorrhage, so they commonly have the tan yellow to tan brown in color. As we said that they are further divided into type 1 and the type 2. So discussing about the type 1, they commonly also known as the basophilic type of the papillary renal cell carcinoma, because they have the papillary type of the architecture, but they have a very little or very scanty cytoplasm. At the same time, relatively they have the very hyperchromatic type of the nucleus. So that is the one reason that they on the low power they appears very bluish. When we compare it to the type 2, the type 2 is very eosinophilic, and they commonly and the predominantly morphologically they have the papillary cores, but they can have a tubules appearance, they can have a glomeruli type of the architecture, or even they can have a solid appearance as well. So as we walk through this presentation, we will touch base on those variants as well. And they are commonly lined by a single layer of the cells which possess very low or very little basophilic appearance of cytoplasm, and they have a low nuclear grade as well. As we discussing about the nuclear grading, when we were discussing about the clear cell carcinomas, that their nucleoli is not much prominent, while when we are discussing about the type 2, we will see in the histology that their nucleoli is much more prominent, and they have the higher nuclear grade compared to the type 1, which has a very low nuclear grade, and their nucleoli is very inconspicuous as well. And oftenly inside their papillary architecture, they contains the foamy macrophages, and then they have the somoma bodies as well. Somoma bodies are histologically they are purplish in color, and they are represents the aggregates of the calcium. They can be seen in many other papillary architecture type of the tumor, such as papillary carcinoma of the thyroid, papillary carcinoma of the ovary, and even they can seen in the meningiomas as well. So they are not very specific. In terms of molecular in origin, it is very important to remember that the type 1 papillary type of the tumor, they commonly seen in the trisomies such as chromosome 3, chromosome 7, and the chromosome 17 in greater than 80% of the cases, and they are very consistent, especially compared to their type 2 version. And they have been seen that they have the MET activating mutations or the amplifications. and their prognosis compared to the type 2 is much more better, and they are commonly lower grade as well. And the IHC, the CK7 is very helpful, and the CK7 is commonly diffusely positive, while it has been seen that it is focally positive in type 2. And CK7 becomes much more important when we have a solid microcystic glomeruli or the tubulopapillary type of the variants. So this is the one picture of the type 1 papillary renal cell carcinoma. On this low power of this histology, we can clearly appreciate that on the outer surface there is a fibrous capsule, and towards the inner side we can completely see a very bluish appearing tumor which has the papillary type of the architecture, and we can also see these purplish type of the aggregates of the calcium which are also known as the Somoma bodies. And if we go on the high power, now we can clearly appreciate the papillary type of the architecture which are lined by a single cuboidal cells. And here we can see that the cytoplasm is little bit very little or very scanty. So that is the one reason, that because the nuclei appears very hyperchromatic, they are also known as the basophilic papillary renal cell carcinoma. We will understand much more when we will compare it with the type 2 version. And inside these papillary cores, we can also appreciate these foamy type of the macrophages on immunohistochemistry. They can be easily stained with the CD68 marker. And these are the other variants of the type 1 papillary renal cell carcinoma. Here, this variant is the microcystic type of the variant. This is the solid type of the variant, and this represents the glomeruli type of the variant. And here we can also see these purplish aggregates of the calcium, which represents the Somoma body. So when we have these type of the variants, the immunohistochemistry, especially the CK7 and the molecular, are very important to diagnose these type 1 papillary renal cell carcinomas. While discussing about the type 2, the type 2 are very eosinophilic, which means they have a much more pinkish and the eosinophilic type of the cytoplasm. And predominantly, they have the papillary type of the cores, which are lined by the pseudo-stratified layers of the cells, which have much more abundant and the pinkish type of the eosinophilic cytoplasm, and they commonly have a higher nuclear grade. So by means of higher nuclear grade, it means on even on the low power, we can clearly see the appearance of the nucleoli. And they are very much heterogeneous in terms of molecular origin. So that is the one reason they carry very poor prognosis compared to their type 1 version. And there are multiple molecular pathways through which the type 2 can arise. So the commons are the activation or the mutation in the NRF2ARE pathway genes. And the second is 25% of the cases they have been seen, there is an alteration in the CDKN2A, and these are most of them are associated with the poor prognosis. Another is the CPG island methylator phenotype, which is also associated with the prognosis. But compared to type 1, overall, they have the much more worse prognosis, and they are much more higher grade. So this is the histology picture of the type 2. So here we can clearly see that there is a papillary type of the architecture in which the cells are lined, and they have the very much abundant and the voluminous cytoplasm, which is very pinkish appearance. So that is the one reason they are also known as the eosinophilic type of the papillary renal cell carcinoma. And on this low power, we can clearly appreciate that they have a prominent nucleoli. So it means they have the higher nuclear grades. And if we do IHC of the CK7, most of the time they have a focal in appearance. So in these type of the cases, when they have a different type of the variance, the molecular becomes much more important. So this is the end of my presentation. Thank you so much.